Right. So we are discussing the human cardiovascular system. Give me a second, guys. This is not working well. Give me a second. I'm just gonna record. Okay, so we're discussing human cardiovascular system. Um, we already have started the lecture, and we're just catching up now to those who are just joining. Okay, we just started recording, so you are meeting this lecture a bit on. So give me a moment here. Let me set up my notes again. My notes got jumbled up while I was taking care of that bit of business. Okay, give me a second. Okay. So we've talked about the four chambers of the heart, the valves. We've talked about the pulmonary and the systemic circulation. We've talked about veins, the heart, veins, arteries, and capillaries. And we've talked about the way the heart contracts and relaxes. And then another thing to note is that this rhythmic contraction and relaxation of the heart is aided by the heart's electrical system. Just like uh, in your home, you have wires running through the walls, right? So that your TV can work, your water heater can work, so the heart works through electricity. And so it has a wiring, okay? Electrical conduction system. All right. And it is what controls the heart rate and rhythm. Okay. There is a place in the heart somewhere here. There's a node. That's where the electrical impulse in the heart starts. It's called the SA node, or the sinoatrial node, somewhere here. So it generates electricity. When it fires electricity, there is a conduction system that runs through here, and it is what causes the rhythmic relaxation and contraction of the heart. Okay, so there are some fibers that conduct this electricity. So there's a conduction system, okay, and so that when you do when you do an EKG, okay, when you do an EKG, it's the electrical impulses in the heart that are being recorded, okay, in an EKG, okay, the way when the electricity is flowing through the heart. So that is what an EKG is. All right. Again, we talked about the blood flow through the heart. Deoxygenated blood enters the right atrium, flows to the right ventricle, and is pumped to the lungs. We saw it here. Deoxygenated blood enters the right atrium, into the right ventricle, pumped into the lungs. Okay. And oxygenated blood returns to the left atrium, flows to the left ventricle, and is pumped to the body. Okay, so oxygenated blood, left atrium, left ventricle, to the body. All right. So that's the way that works. Um, um, mm, let's see. Let me just put a few comments here about the electrical conducting system. Okay, so understanding the heart's electrical system is crucial for medical encounters related to arrhythmias, ECGs, and cardiac procedures. So the basic concept is this: the heart's electrical system generates and conducts electrical impulses that coordinates the contraction of heart muscle, ensuring efficient blood flow. Automaticity. The heart has the unique ability to generate its own electrical impulses, independent of the nervous system. Conductivity. The heart's specialized cells can conduct these electrical impulses throughout the heart muscles. So these are three important concepts. Okay. Like I said, the components of the electrical conductive system, the sinoatrial node. So this is heart's natural pacemaker. So it is when this natural pacemaker is not functioning well. You've heard of people getting the pacemaker, installed in their chest. So it's when this is not functioning well. So it's located in the right atrium, sorry. It generates electrical impulses and initiates the heartbeat. It sets the normal heart rate. All right, and that's called the sinus. And then there are other parts that we won't. I'll just give their names. I won't give more detail into them. Okay. Yeah, there are other parts of the system. Okay, it's not necessary for us to know all of that. Let me go on to let's do this. Okay. Like we said, the SA node generates an electrical impulse. The impulse travels through the atria, causing them to contract. The impulse reaches something called the AV node, which is the atrioventricular node, which means it's located between the atria and the ventricles. That's one of the names. I didn't want to go into more details, but anyway, there's something called the AV node. The impulse travels through the bundle of His bundle branches and Purkinje fibers. These are all part of the conduction system. You don't need to know the names, but and then the ventricles contract. So that's what happens. So impulse starts from the SA node. It's when that happens, when impulse travels through the atria contracts. When the atria contracts, the ventricle relaxes. Okay, the blood flows into the ventricles. By the time the fluid has flowed into the ventricle, the electrical impulse has also reached all of the ventricles, and when the electrical impulse gets there, the ventricles contract and pumps blood out. So see the way it's arranged, right? It's everything is perfectly timed, to function well together. So key terms and concepts for interpreters: sinus rhythm is a normal rhythm of the heart. It starts from the SA node. So when you talk about arrhythmia, okay, It's an abnormal heart rhythm. Okay. I'm sure you might have seen adverts on TV. Maybe not. Maybe not. Anyway, if you watch American TV, for something called atrial fibrillation, anyway, arrhythmia is or dysrhythmia is abnormal heart rhythm. So bradycardia is a slow heart rate less than 60 beats per minute. Tachycardia means a fast heart rate more than 100 beats per minute. Okay. Now for an unborn child, okay, that normal heart rate is around 144 per minute. It's almost twice that of an adult. An adult, your heart rate is somewhere in the 70s, normal. But for the child, if your child is inside in the uterus, the heart rate is 144. So atrial fibrillation is a common arrhythmia caused by rapid, irregular atrial contractions. And then there's ventricular fibrillation. And then we've talked about electrocardiogram. I said it's a recording of heart electrical activity. Pacemaker, I mentioned pacemaker, a device that generates electrical impulses to regulate heart rhythm. So if the SA node is not functioning well, then they have to put a pacemaker somewhere there, to help the heart out. Okay. And then defibrillation is, I'm sure you've watched it on TV when they say, they're saying the president, they show the heart fast, has flattened. They'll get some pads, put some pads, with an electric shock. That's defibrillation. Okay. All right. So let's look at some common cardiovascular conditions. Of course, hypertension. Okay. Coronary artery disease, which means blockage of coronary arteries. All right. The coronary arteries are arteries that take blood to the heart. We call them the coronary arteries. Okay. Where are we? Give a second. Let's look at the coronary arteries. Okay, so let's look at coronary artery disease, what it looks like. Okay, so this is what you call coronary artery disease. Okay, let's push it. Okay, this is coronary artery disease. This coronary artery is the arteries that supply blood to the heart. So you call them, these are coronary arteries. Okay, so the blood itself has a blood supply coming from here. So this is the blood supply to the heart. Okay, so when it becomes blocked, you call that coronary artery disease. So blockage of coronary arteries, reducing blood flow to the heart muscle. So the heart itself needs blood supply. And blood to the heart is supplied by what you call the coronary arteries. So typically when you have coronary artery disease, it can lead to angina or chest pain. Okay, you have chest pain. And then, heart attack, myocardial infarction. Okay. Yeah. So the other thing that we can have is heart failure. That's when the heart failure is when the heart is weak. The muscle, the heart is a muscle. So when the muscle becomes weak for whatever reason, okay, you have heart failure. Okay, the heart is unable to pump enough blood to meet the body's needs. Okay, défaillance. Okay, radio de cœur bloqué. Okay. Of course, we've mentioned arrhythmias, which is irregular heart rhythm, either atrial fibrillation or ventricular fibrillation, or the other types of arrhythmias. Then, then there can be valve diseases. Okay, diseases of the heart valves. Okay, affecting blood flow.
Ingurgitation.
Sorry?
Ingurgitation.
Yes, it could cause regurgitation, or not. Regurgitation is when the blood is not flowing back.
Yeah.
Okay. Or there could be stenosis, which means that the heart, the vessel, the valve is tight. Instead of opening up and closing, opening up and closing, it doesn't open up completely. So that can be a problem. So regurgitate is like they go in remontance. So that's regurgitation. So that is when the valves are weak. Okay, but when the valves also are thickened, then they won't allow blood to. So stroke is another common condition. Of course, when blood supply to the brain is interrupted, either it could be interrupted if a vessel bursts. Okay, you call that a hemorrhagic stroke. Okay, or if a plaque like this forms in the vessel in the head and becomes blocked, you call that a hemorrhagic stroke, or what's the other type of stroke? Maybe I think occlusive stroke. Let me check that name. Occlusive. No, it's not stroke. Types of stroke. Ischemic. Okay, it's called an ischemic stroke. Ischemic, not occlusive. The proper word is ischemic stroke. Okay, which means that blood is well, actually, so we have two types of stroke: hemorrhagic and occlusive. I guess it's called occlusive. Okay, so whether there's a blockage in the vessel or the vessel bursts, if your water main the water supply to your house, if the tube bursts outside, the water won't come to your house, right? It's not blocked; it's just burst. Okay, so whether it's hemorrhagic is that occlusive is that it's blocked. Hemorrhagic is still open but it's burst. Okay, so that's stroke. There's also peripheral artery disease. It's narrowing of the arteries in the limbs, reducing blood flow. So that occurs a lot in things like diabetes. Okay, diabetes. When there's diabetes and there's peripheral artery disease, blood flow to the extremities, the feet becomes very poor, such that if you have a wound, it won't heal well, right? So that it won't heal well, and then you have an ulcer that just doesn't heal, and it becomes gangrene, and often they will have to amputate. Okay, that's peripheral artery disease. I had a patient who diabetic. I think she had type 1 diabetes. She picked her cuticle from her nail. She lost that finger. Picked her cuticle, and it just got infected and she lost the finger. So here people that have diabetes, they don't allow you cut your nails by yourself. You have to go to podiatrist to have your nails cut your nails. Okay, so what tests do we perform for cardiovascular system diseases? EKG, we've talked about EKG. Okay. Then there's echocardiogram. Okay. Let me tell you what an echocardiogram is. Echo. You know what EKG is, right? I don't have to tell you that. Echocardiogram.
Yeah. Echo is sound.
Yes, echo is sound. So this is how an echo is done. So this is an echo. Okay.
Mm-hmm.
So I using they use this echo, this using ultrasound, okay, to visualize the heart structure and function as an echo being done. Okay. Echocardiogram. And then stress test. If you complain that you often have pain in your chest, you walk on a machine while they're checking you. So this guy is probably going to do an stress test. So to do the stress test, you do the echo with the patient at rest. Then you get up from the bed, jump on the treadmill and exercise. And while that you're exercising, they're checking your EKG, they're checking your blood pressure, okay? And as soon as you're done exercising, while your heart is still racing, you go and lie down and they do repeat the echo, okay? So that's how the stress test is done. Then there's cardiac catheterization and angiography, okay? Cardiac catheterization, let me show you in a second. And all of these things, you go to YouTube, you will see you'll see the procedure being done. Okay.
Mm-hmm.
See. Yeah. And let me put this link here. So if you click on this link, it should take you to someone on YouTube and to show you.
Is an X-ray examination of the vessels and chambers of the heart, often done to identify any narrowed or clogged coronary arteries that are preventing blood from reaching the heart muscle. The study can also be used to measure the size and function of the chambers of the heart and the function of the heart valves. When you arrive at the hospital, an intravenous line will be started. You will be placed on a heart monitor, and you may be given an oral or intravenous sedative to help you relax. Most coronary angiography procedures last between 1 and 2 hours. Before the procedure, you will be placed on a table equipped with a fluoroscope, an X-ray imaging device. During the procedure, the fluoroscope...
All right. So like I said, when you click on that, you will see, when you see something like this, you open it and watch it too, depending on how much time you have. All right. If you need more information, okay. So this is what all right, we don't have time. I won't go into it. Beyond that, let's try this one. And I'm gonna put angiography. I'm gonna put another link here. So let's look at this link.
Your doctor has recommended a cardiac catheterization, also called a cardiac cath. It is a procedure to examine your heart. This video will help you to understand this procedure. Let's begin by reviewing information about your body. Your heart is in the middle of your chest, under your ribs. It is the muscle that pumps blood to the
Again, you have that. Won't go into it. So you look at it when you get the notes.
Okay. You will post it for us.
Yes, of course.
Okay.
Other blood tests, cholesterol level, cardiac enzymes. Okay. Holter monitor. So it's a portable ECG that records activities over 24 to 48 hours. So they'll, if they want to find out how your heart is behaving, they will give you a Holter monitor to wear. Okay. Then of course there's CT scan and MRI and things like that. Holter monitor. So put a thing here. All right, so there's a link there. And then, treatments, lifestyle modification, medications, depending on what you have. So antihypertensives, cholesterol, antiplatelet medications, and then medical procedures. Let me give you a bit more detail on this.
Stand. Let's look at implantation. Implanted local. Sure.
Okay. All right, so this is medical procedures, surgeries for cardiovascular conditions. Okay, so it gives you a bit more detail here. Angioplasty, then coronary artery bypass grafting called cabbage. Major open heart to bypass blocked coronary arteries. Pacemaker installation, implantable cardioverter defibrillator, and valve repair or replacement. Okay, so this is what you need to do. Be familiar with terminology. And then, of course, there's cardiac rehab. Okay, so different. So okay. So the key considerations for medical interpreters, things that are important, you need to take note of. Okay. Okay, that's it. That's it for cardiovascular system. Let's take 5 minutes and come back and look at the respiratory system.
Pour 5 minutes? 5 ou 15 minutes? Oh. Ah! Oh! Comme des sports. Là, fais sport, musculation, bravo. Des vidéos. Ah, bonne nouvelle.
Right, so we're looking at the respiratory system. It's a bit bigger. All right. Very clear. Sorry. Okay, well, all right, let's get back to it. So the respiratory well, anatomically we divide the respiratory tract into the upper system or tract. Okay, we can call it tract or system. We talked about the
Make it bigger,
upper.
please.
Sorry?
Make it bigger, please.
Okay. Okay, so we're looking at the respiratory system, okay? Anatomy and physiology, components, upper respiratory tract, which is the nose, the nasal cavity, and the pharynx and the larynx. That's the upper respiratory tract. Okay. And then lower respiratory tract would be the trachea, okay, the bronchi, the bronchioles, the alveoli, and then the lungs and the diaphragm. Okay, we'll see all of them. All right. It's not a very good picture. Let's see if we can take it. Let me see if I can get a better picture of that. I want us to see. We'll see what we can find. I want to show this the epiglottis well. Okay. Okay, so this is the upper respiratory system, okay? The nose, the nostril, the pharynx, and then the larynx. So remember that this is an important structure, the epiglottis. Okay, this is what so this is the airway, this is the esophagus, this one, and this is the mouth. So you know when you swallow food here, there's your tongue. When you swallow food, it comes here, and you don't want it going down here, right? So what happens is that this epiglottis closes and covers this opening, like a door or a window, covers this, and the food slides over it. Which is why if you're at risk of aspirating food if you are talking while you're eating, which we do a lot. Because if the epiglottis doesn't close, or if when somebody is like when somebody has when you have anesthesia, you know, so if you're going to have a procedure where you're going to have anesthesia, right? They tell you don't eat because the epiglottis the gag swallowing reflex, you lose your swallowing reflex when you're under anesthesia. And if you have food in your stomach, you're going to vomit and it's going to go into your lungs, which is why they insist that you haven't eaten for 24 hours, for a good length of time before you have anesthesia. Okay, so you don't aspirate. All right. So that is the upper respiratory tract. Okay. All right. So that's that. Okay. Okay. And then of course we said the lower respiratory tract is your trachea and then the diaphragm as well. That's done in that picture. So, okay. So this is the upper, there's the lower. So that you see the diaphragm is actually a very important part of your respiratory system. Okay. And these are the alveoli. This is where exchange of gases takes place in the alveoli. Okay. So let's let's see what okay. Anyway, that's fine. I can put up a video for you to look at. All right, let me add a few. You can see this here. All right, I'll put a video here, and you can take a look at this. Again, like I said, when you look at one, something else shows up. You click on it and watch it. Okay. All right. So as far as the physiology goes, respiration is a process of exchange between lungs, of gas exchange between the lungs and the blood. Okay. So inhalation is inspiration, air enters the lungs. Exhalation, air exits the lungs. And gas exchange is oxygen from the inhaled air diffuses into the blood in the alveoli. Carbon dioxide from the blood diffuses into the alveoli to be exhaled. Okay, and the breathing mechanism, the diaphragm, okay, and the intercostal muscles control breathing. Okay, and changes in chest cavity volume create pressure difference and drive airflow. So when the diaphragm I think when diaphragm contracts, it stretches. I can't quite remember which way it is now. Anyway, when the diaphragm lowers down, it's like if you are trying to, if you put a balloon in your mouth and you inside your mouth and you suck, when the balloon expands, air is going to flow into it. So that's how breathing occurs. Okay, when the volume expands, air comes in. When it contracts, it presses. Okay, presses, and you exhale. So that's inhalation and exhalation. That's the way that goes. That's the breathing process. All right. So yeah, we understand that. And and that the gas exchange takes place in the alveoli. Okay. All right. So these are the, let me give okay. So this is let's look at, this is what happens this is what the alveoli look like. Okay, so you can see the capillaries surrounding it, right? Okay, this is the artery bringing oxygenated blood. These are the capillaries. Okay, and gas exchange takes place here, and then so oxygen flows into the alveoli, and the blood now goes back as deoxygenated blood. Okay, so this is what happens in the alveoli. This is what is happening. Okay, this is what's happening. All right. So carbon dioxide leaves the bloodstream. Okay. And oxygen enters the bloodstream, blood vessel. So this was happening in the lungs. Okay. And of course, breathing mechanism and common conditions, asthma, COPD, pneumonia, bronchitis, pneumothorax, pulmonary embolism, lung cancer, sleep apnea, cystic fibrosis, tuberculosis. Okay. Tests, pulmonary function tests. So now, do you know what is pulmonary function test? Do you know what is pulmonary function test? Do you know what is a pulmonary function test?
No, I didn't know about it. I didn't know about it.
Enoch, you're muted.
Okay. Lungs deal with inhalation and exhalation.
Yeah.
Thus, a pulmonary function test is a test which is done to learn about the airflow in the lung.
All right. Okay, well, let's.
Maximum voluntary ventilation. Welcome to the Columbus Community Hospital Pulmonary Function Lab. These tests are also referred to as PFTs or breathing tests. They are done to measure how well your lungs take in and exhale air. They also measure how well your lungs transfer the oxygen from the lungs to the bloodstream. Depending on your doctor's orders, you may be doing up to 4 different types of tests today. This is the machine that we use to perform your PFTs. It may appear to be a confined space. So if you have any problems with claustrophobia, please let us know and we will work with you. You will be asked to wear nose clips and place your lips around the mouthpiece, forming a tight seal at the start of each test. Spirometry is the measurement of the amount of air you can move during a single deep breath and the speed at which you can exhale the air. In this test, you will start out with your nose clips on and your mouth around the mouthpiece. You'll be asked to take a few normal breaths on the mouthpiece before taking a big deep breath. Once that deep breath is in, you will immediately blast your air out all the way until you are instructed to take a deep breath back in. This test may be repeated 3 or more times to make sure we have your best efforts recorded. Maximum voluntary ventilation, also known as MVV, is the measurement.
Once again, you in your own time, you go and take a look at that. Where are we? Okay. Let's. Okay, gonna look at what that is. Is this what we were? No, this is not what we were. Sorry, lost my place again. Where we are. Now, bronchoscopy. All right, bronchoscopy, maybe one you don't know what's. Let's see what the bronchoscopy is.
Your doctor may perform a bronchoscopy to look for and diagnose problems inside your lungs. Your nose and mouth are points of entry for air to move in and out of your lungs through your trachea or windpipe and bronchial tubes. With each breath, your lungs inhale oxygen and exhale carbon dioxide. This exchange of gases is the way your body gets oxygen into your blood. A bronchoscopy may be done to look for and possibly retrieve a foreign object that may have been inhaled instead of swallowed, investigate a persistent cough or a cough producing blood, obtain a mucus, tissue, or liquid sample from inside your lungs, or evaluate an abnormal chest X-ray or CT scan. Before your procedure, you will receive medication to help you relax and minimize coughing. An intravenous line will be inserted for additional medications. Your heart and blood pressure will be monitored, and you will be given extra oxygen during the procedure. You will be given either a local anesthetic to numb your throat or general anesthesia. During the procedure, your doctor will slowly thread a bronchoscope through your nose or mouth, down your throat, past your vocal cords, through your trachea, and into your bronchial tubes. He or she will carefully examine the lining of your airways and may take samples for laboratory examination or remove a foreign object. After the procedure, you will be taken to a recovery area. If a biopsy has been taken, you will likely have a chest X-ray before you leave the hospital. Your doctor will send any
Okay, so that is that. Let's go back here again. All right. So this is where we are. So that was a bronchoscopy. What else? So pneumothorax, bronchitis, pulmonary embolism. It just means blood clot in the lungs. Okay, pulmonary embolism, blood clot in the lungs. Okay, again, I'll put a video of that.
Or its branches, blocking.
So let me put so you watch that. I think the other one should be obvious, but the ones I think might create a problem, we'll attach a note. Okay. Pneumonia, you know what pneumonia is, right? Pneumonia. Bronchitis, pneumothorax. Pneumothorax is a collapsed lung.
What does collapsed mean?
Means collapsed. Means the lung has collapsed.
That say the lungs doesn't function anymore.
I mean, it's a Leogan pan caoutchouc.
Okay.
You know, if you put air in it, it will
hold.
Yeah, it will come back again. Well, let's watch this.
Okay.
Hi, this is Tom from ZeroToFinals.com. In this video, I'm going to be going through pneumothorax. And you can find written notes on this topic at ZeroToFinals.com/pneumothorax, or in the respiratory section of the Zero to Finals medicine books. Is a young, tall, thin young man presenting with sudden shortness of breath and pleuritic chest pain, possibly whilst playing sports. So if you see a patient like this appear in your exam, think about a pneumothorax. Let's talk about the causes. Like we said, it can be spontaneous. So a pneumothorax can occur for apparently no reason. It can be secondary to trauma. So think about it if somebody's been in a bicycle accident or a traffic.
This is a bit too detailed. Let's see if we can find something. This is for medical students, which we don't need. So let's see if we can find something else that is a bit less Well, the sound. No sound. Not very useful, no sound. Yeah, well.
The lung has a perforation.
Yeah. Like say talk get panka cheap. Like if you have a hole, then the air comes out and it collapses. If you seal it off, if you block it off. But the only problem is that when the air escapes from the lungs, you know, in the case of your car, it goes out into the air, but the lung is inside. So when the air comes out, the air comes into the space outside the lung, so that it then presses the air. As you are breathing, more air is coming in and then pressing on the lungs. So that's what causes the lung to collapse. So I wonder why there's no sound. And this is a good one, but there's no sound. No, my sound is up. Yeah, there's no sound. Okay. It's not useful for us. Let's see if we can find another one. Anyway, that's generally pneumothorax. Okay, well, let's see. Still no sound. Yeah, no sound.
But we listen.
Yeah. So you see the air, this place is the air now escapes into the space, right? And then it now presses on the lungs. So you see that this lung has become smaller. Okay, which means you're not getting enough air. Okay, so that's what in the thorax will cause a collapsed lung. So anyway, you can search around and see what.
Hi, I'm Kathy with Level Up RN.
Oh.
In this video, we are going to talk about pleural disorders as well as chest tubes and a tension pneumothorax. And at the end of the video, I will give you guys a little quiz to test your understanding of some of the information I'll be covering in this video. So definitely stay tuned for that. So.
All right, well, I'll copy that and then you can watch that one since that one has sound. Okay. All right, let's move on. Okay. So that's it for the conditions. For the tests, we already talked about pulmonary function test, bronchoscopy, arterial blood gases analysis. Anything you don't understand, just search it. Okay. Pulse oximetry. If you don't understand it, just do a search. Treatments, bronchodilators, corticosteroids, antibiotics, mucolytics, okay, to thin the mucus, okay. Bronchodilators if you have asthma, albuterol, okay. Corticosteroids to reduce airway inflammation, prednisone, then nebulizer, chest physiotherapy, because they want, like a patient after surgery, you want to encourage them to cough up mucus. So that's what they do what they call chest physiotherapy, mechanical ventilation, pulmonary rehab, surgical procedures, thoracocentesis. So this is what you do to relieve a hydrothorax. So let's put that there. Let's look at thoracocentesis.
Wait, the prefaces and the suffixes will
Inside
have.
of the chest cavity.
Sorry. Go ahead. Go ahead.
Okay. I was saying that the suffixes and the prefixes will help us understand.
Sorry? What do you say?
I said that the suffixes and the prefixes will help us understand.
Yeah, that's true.
Inside of the chest cavity. The pleural space can be.
So let's put this. So that's thoracocentesis. It explains to you what thoracocentesis is. Just like you said, the medical terminology understanding will help you understand what it is. But I'll put a video there. Lung resection is to remove lung tissue. Tracheostomy to create an opening in the trachea for breathing. Okay. And these are some important things. Okay. So we'll stop here. Let's go back. All right, questions. Questions.
I think that a medical interpreter is not really a physician.
It's not really a physician.
A doctor.
Okay, go ahead.
So I think that you are not too obliged to know everything about the procedures, but just able to interpret the terms. And I think that the patient, if they want to know more about the thing, would ask the doctor, what does that mean?
Very true. Very true. That's true. Any other questions?
But we need to be familiar with those terminology.
Yes.
Because when the doctor says something, so you know how to translate it to the patient.
Yeah. So that's why we say familiarize yourself with respiratory system terminology. When you do this, you can help patient understand that, conditions, tests, and treatment. Okay. So if you understand, then you are also better able to communicate with the patient. So any questions, any of these terms you want? You have questions? Any questions?
Let me see the procedures again, please. The procedures again, please.
Yeah. I'll go in there.
Yeah. The procedures. Guess, something with guess.
Yes.
It is.
This one?
Okay, arterial blood gas analysis. I'd like to see a video about it.
Go ahead.
Hi, I'm Kathy, and in this video series, I will be covering arterial blood gas interpretation, or ABG interpretation. I'll be covering a number of topics, including the ABG components and what the normal expected ranges of each component are.
Well,
we'll talk about buffers in the body that help maintain acid-base balance, different acid-base imbalances. Video series. However, it is really that is used to assess the acid-base balance. So what is an ABG? An ABG is an arterial blood sample that is used to assess the acid-base balance, the ventilation and oxygenation of a patient. These are often critical care patients, but I also had patients when I worked on the med-surg telefloor who would get ABG tests done routinely. So, like I said, it's an arterial blood sample. So this is not a venous blood sample. We need to get it from an artery. So we're not pulling it out of a PICC line. We either need to take that arterial blood sample out of a functioning arterial line, and patients who have arterial lines are typically in the ICU, or we can get it through a puncture. So at my hospital and at many hospital systems, the respiratory therapist is the one who actually comes and does the blood draw for an ABG. So they will typically get that blood sample from the radial artery. Before they do the puncture, however, they do what's called an Allen's test. So an Allen's test is done to make sure that we can get adequate blood flow through the ulnar artery while we're messing with that radial artery. So with the Allen's test, we're compressing both of those arteries, and the hand will get kind of pale and cool. We'll let go of the ulnar artery, but keep compressing the radial artery to make sure we get blood flow back to that hand, and that artery can supply that blood flow while we're getting the blood sample out of the radial artery. So that's an Allen's test. So with ABGs, it's all A's, right? We're getting our arterial blood sample and we're using an Allen's test. After we get the sample and
again, this is a bit too detailed, for nursing students, and we're not training to be nursing students, we're training to be interpreters, so we will not bother with that.
Arterial blood gas, ABG, is a blood test that measures the levels of blood oxygen and carbon dioxide, as well as blood pH, in a sample drawn from an artery, most often from the radial artery or femoral artery. ABG is ABG is typically.
So I will attach this, and then you can. This is not too much, so I will attach this. You can watch that. All right, that's it. Anything else? Anything else?
I guess we are waiting on you to send them in so we could begin to study more on them.
Yeah, definitely. So let's see. Let me stop share for a second, and maybe we'll look at some of the let's go and look at some of the material on the
I've been really, really wanting to do this video for a very long time, because I think it's something very, very important. So in this video, I'm going to briefly be comparing what I like to call the big three medical interpreting codes of ethics. So we need to remember that there are actually 3 widely recognized codes of ethics for medical interpreters. For spoken language interpreters, these codes of ethics are required knowledge for both the CCHI and NBCMI certification exams. So of course here what I'm going to be talking about today has to do with certification by the major certifying bodies in the United States for medical and healthcare interpreters. So why compare medical interpreting codes of ethics? Well, like I said, they're required knowledge for both the national medical and healthcare certification exams for medical interpreters. But because you need to know it to pass a test is a kind of lazy answer. Like many folks, I read all 3 codes of ethics for my first certification exam, but I didn't really absorb them. It was only when I became an interpreter trainer, putting together my ethics classes, did I begin to look at all 3 more in depth. And only upon looking at the codes of ethics this way, comparing and contrasting similarities and differences, did I begin to truly internalize and more fully understand the ethical framework we should be working within as medical interpreters. I truly believe it has helped me to become a better interpreter. Point blank. So real quick, let's take a peek at and compare the different codes of ethics for medical and healthcare interpreters. We're told to be familiar with all 3 codes of ethics from these organizations. So we have the NCIHC, the IMIA, and CHIA. Now, does anyone know what the acronyms for these organizations stand for? That's kind of the first part here, really important, because these are really big organizations and they do a lot for the field of medical interpreting. So the NCIHC is the National Council on Interpreting in Healthcare, and they have their National Code of Ethics for Interpreters in Healthcare. The IMIA is the International Medical Interpreters Association. So IMIA is actually the kind of like parent organization of the NBCMI. And the IMIA actually authored the first Code of Ethics for medical interpreters. So kind of a big deal. We should really, at the very least, be somewhat familiar with the IMIA Code of Ethics. It's very short and sweet and goes straight to the point, which is nice. CHIA, the California Healthcare Interpreting Association. They have their ethical principles for healthcare interpreters. It's included in their California standards for healthcare interpreters. Even if you're not in the state of California, CHIA's Code of Ethics is pretty legit. They have their ethical decision-making process within their standards of practice, which, you know, even if you're going over ethics from the NCIHC, you gotta know about this ethical decision-making process. CHIA is really nice, their Code of Ethics, in the sense that it's very in-depth, very detailed, so it really helps you to kind of understand the ethical principles as outlined by the NCIHC in a little bit more depth. So they all have something different to bring to the table. So speaking of tables, I created this handy little table comparing and contrasting the different codes of ethics. So the NCIHC's Code of Ethics has 9 tenets, but there are common themes among these tenets as they outline in the 3 core values: beneficence, fidelity, and respect for culture. So beneficence is basically health and well-being. So we also have fidelity, which is faithfulness, like Fido the dog, fidelity, Fido. It is faithfulness to the message. So making sure that you're interpreting everything accurately and completely. And respect for culture, which I think is pretty self-explanatory. So the 9 ethical principles as outlined by the NCIHC are, in no particular order, advocacy. So advocacy tells us when we can advocate for a patient. So it's when their health, well-being, or dignity is at risk. We have confidentiality. Again, I feel like that's pretty self-explanatory. However, there are some key differences between these 3 codes of ethics in terms of what they say about confidentiality. We have impartiality, which means that you can't insert your own opinions, beliefs, you can't counsel patients, you cannot filter your interpretations through your own biases. Maintaining boundaries, that's all about staying within the medical interpreter's role. You have treat all parties with respect. I think that's pretty self-explanatory. However, it's important to note that respect includes respecting a patient's autonomy, their ability to make their own decisions. And then we have professionalism, which isn't so much, a lot of people like to think about this as, you wear your fancy 3-piece suit. Not so much. It's more along the lines of acting with integrity, behaving in a manner that is befitting of our profession. Professional development is all about expanding your knowledge and your skill set, constantly seeking to improve yourself as a medical interpreter. Accuracy, I like to think that one's self-explanatory. We're going to interpret everything accurately and completely. And then we have cultural awareness, which is having cultural knowledge, expanding your cultural knowledge, being aware of cultural differences and their implications. So that's long and short of the NCIHC Code of Ethics. The IMIA Code of Ethics has 12 ethical tenets, but a lot of them overlap with other tenets from the NCIHC and CHIA. I'm not going to go through all tenets in order, but I'm going to relate them back to the categories we've established thus far with NCIHC. So confidentiality, of course, we have that. It's important to note that we don't have anything that talks about the health, well-being, and dignity of the patient. We have impartiality. We do have don't interpret for family or close personal relationships, don't interject personal opinions. That's in line with impartiality. Maintaining boundaries. So maintaining boundaries doesn't say in general that we should maintain the boundaries of the professional role, but it does specifically mention the advocacy role and the cultural mediation role, and that you should only do those things only when necessary. We're going to skip right down because we don't have anything that specifically mentions the word respect. However, we have right below professionalism. I mentioned integrity here, and you'll see why here in a moment when I start talking about CHIA's ethical principles for healthcare interpreters. I think it's really interesting that IMIA points out that we shouldn't use our position to gain favors from clients. I like that that's included because I think that mentioning that outright is important. So professionalism doesn't mention the word professionalism, but it does say don't take assignments outside of your skill level or scope of your training. So you're going to recognize your professional limitations. You need to stick to healthcare interpretation unless you have training in other interpreting specialties. We also have professional development. Now, it doesn't, again, mention the term professional development. However, it does say stay up to date on evolving language and terminology, that you should participate in continuing education, and that you should maintain ties with professional organizations. Now, for cultural awareness, we do have a mention of the cultural mediation role that says you should only engage in it only when necessary, but it doesn't say anything in particular about expanding your cultural knowledge, at least not in the Code of Ethics. So, of course, you have to keep in mind that these organizations have their Code of Ethics, and they also have their standards of practice, and oftentimes those standards of practice will expand upon these ethical principles a little bit more. So we have accuracy, of course, does not have one particular thing that says accuracy, but it does say to choose the correct mode of interpretation, which we do this to make sure that we're being as accurate as possible, right? If someone is speaking in very long, rambling phrases and we don't have an opportunity to stop them and they keep on going on, it might be more appropriate to switch to simultaneous, if possible, to maintain accuracy. It also mentions to choose the correct language, register, etc., and to also convey that, quote, spirit of the message. Now, a big reason why I like to look at IMIA and their Code of Ethics for medical interpreters is because they mention something that this is something that is mentioned in the standards of practice for some of the other medical interpreting organizations. However, I like that this is stated outright. And I think that this is something that is valuable in and of itself. It's intrinsically valuable, using unobtrusive interventions to maintain the flow of communication. So the NCIHC lays out as part of the accuracy ethical principle that we need to manage this flow of communication. But I like the fact that IMA kind of puts front and center that those unobtrusive means being unobtrusive is intrinsically valuable, and this sort of flow state, flow of communication, is intrinsically valuable. So I just like to draw attention to this, maybe not necessarily as an additional ethical principle, but something that IMIA really puts front and center that I find that is very valuable, because I often see interpreters using interventions that aren't as unobtrusive as they could be, not really fading into the background as much as I feel like they should be as an interpreter. And I really think one of my favorite things when I'm interpreting is when we hit that flow state. When I feel as if my presence there, I'm facilitating that communication as if I weren't even there. That these two people who don't even speak the same language are able to communicate as if they were. And I think that is something that is just super, super valuable. So I really like that IMIA mentions this. So that's kind of my long and short of the IMIA Code of Ethics as it compares to the NCIHC Code of Ethics. Now we're going to move on to CHIA's ethical principles for healthcare interpreters, which is embedded in their California standards for healthcare interpreters. So CHIA's standards for healthcare interpreters include 6 ethical principles for healthcare interpreters. Now, these are meant to be taken into account with the health and well-being of the patient, always in the back of your mind. So these codes of ethics don't really have a definitive ranking in terms of what ethical principles we should prioritize over others. And the NCIHC, their ethical principle of advocacy says that we should step into the advocate role when the health, well-being, or dignity of the patient is at risk. CHIA takes a different kind of approach on this, that we're always to have the health and well-being of the patient in mind. I like this because if we think about like the Hippocratic Oath, for instance, the health and well-being of the patient is of primary importance. So being in the healthcare system, being a medical interpreter, we should have the health and well-being of the patient on our minds at all times. I like this. We, of course, have confidentiality again. We have impartiality as an ethical principle. We have respect. Now, respect, instead of treat all parties with respect, we have respect for individuals and their communities. Slightly different, at least in wording. Now, the reason why for IMIA I put professionalism and integrity, I already previously spoke about this briefly, but CHIA specifically mentions integrity in its ethical principle of professionalism. It's called professionalism and integrity. I do like this. I do like that we have this specific calling out of integrity, that this is, again, put front and center. Now, in professionalism, in some of its performance measures, we do mention some things that are in line with the ethical principle of professional development as outlined by the NCIHC, but we don't have a separate ethical principle for professional development. I think it's better to be more explicit with these things because sometimes folks see professionalism and it's almost as if they turn a blind eye to this professional development component. So I do like.
Let me put these things up on our site so that you can go ahead and review yesterday's and today's lecture. All right. And of course, there will be quizzes, a bunch of quizzes during the week. Okay.
Yeah.
All right. So I guess we'll wrap it up here and I'll put all the material on our site. Okay. Have a great night.
Have a good night.
Thank you. Same to you.
Yes.
See you next week.
Yes. Thank you.